Okay, so yeah. So today we'll discuss the disorders that relate of the pulmonary system or respiratory system, and we have two different sets of so non-infectious, and then we'll discuss the infectious diseases. So the non-infectious diseases, which is in chapter 27, which is the asthma, COPD, lung cancer, and then the infectious diseases, which is in chapter 28. So first of all, in chapter 27, as we try to differentiate between the obstructive lung disease and the restrictive lung disease. Anyone can give examples of obstructive versus restrictive lung disease? Obstructive versus restrictive.
An obstructive lung disease would be COPD.
Chronic, obstructive lung disease, which is COPD. From the name, it's obstructive, such as bronchitis, which is chronic bronchitis, emphysema, bronchiectasis, like in cystic fibrosis, asthma, right? Another example of that, obstructive lung disease. Asthma also is an obstructive lung disease. And restrictive lung disease, such as the poliomyelitis, it affects also the muscles of respiration too. Myasthenia gravis, we'll discuss this in Adult Health 3, which relates to the muscles, which eventually affect the muscles of respiration. Pneumonia is considered, yes.
ALS, Lou Gehrig's disease.
Yeah, ALS doesn't much affect the eventually it may affect, but it's not really called or classified as restrictive. It's not. So we have the COVID-19 health screening for myasthenia gravis is one of them. Scoliosis, another one. The poliomyelitis, pneumonia, ARDS, acute respiratory distress syndrome. Pulmonary edema, another one. So let me just get my pointer. Okay. So the pathophysiology, we are going to skip all these slides because these are pure patho. So starting with asthma as one of the obstructive pulmonary lung diseases. And we all know how the prevalence of asthma, how it's quite high, and then in terms of number of people are affected by asthma and the increasing number of people affected by the disease, in addition to the number of annual hospitalizations. Daily there are 1,000 and about 500, like 500,000 cases being hospitalized annual each year. So, and the cost, on the healthcare system, the burden of the financial burden on the healthcare system. So it's quite one of the important diseases that we have to highlight and discuss today. So in terms of etiology and genetic risk, there is a genetic predisposition to it. So the research studies, or what is called the GWAS, which is the genome-wide association studies, they have indicated that there are more than 50 gene variations responsible for the development of this disease. So the disease is caused by, you hear that all the time from patients. They, certain things, they trigger the attack, right? The asthmatic attack. Asthmatic attack is triggered when they are, inhaling something, or when they are near something, or they are exposed to substance, or so these are specific allergens. They are irritants or microorganisms, or even some medications. Some, will be sensitized to what is called, to the aspirin, salicylic acid, and that may trigger the asthmatic attack. So we have a wide variety of, of scenarios and cases, and, and substances and factors that may trigger the attack. So the allergens, you can include a large number of the allergens. What could, from experience, or from, from those who, if you are had to take care of patients with asthma, or if you had known, people with asthma, what would you include under the allergens as the things that may trigger the attack? And patients should be like, avoid, and, always like, away from these triggering factors. So what would be the examples of the allergens that may exaggerate the immune system, which is, we know that from patho, is going to elicit the immune reaction, which is the IgE, right? IgE reaction or immune response.
Physical exercise could trigger.
Yeah, that would be one of the triggers. Yeah, like the strength exercise. What else?
Dust and mold.
Right.
Like
What else?
tender.
Right. That tender, yeah.
Maybe some medications.
Medications, we said, like, the aspirin too. Even pollens, as I said, mold, the animal dander, the dust mites, even some would be like, very allergic to the cockroaches. Some, yeah. So there's a wide variety of, or different, like, types of, allergens. And like unlimited number of allergens. So, but it's very individualized. And exercise as well, we said, because that will be characterized by, by the bronchospasm, shortness of breath, coughing, and wheezing, and so the respiratory infections, also another one. There's a triad of the asthma in terms of the signs, symptoms, and manifestations of patients who experience asthma. They experience or develop three main things: nasal polyps, or that could result in, they develop these symptoms because of nasal polyps, and asthma and sensitivity. They are sensitive to certain allergens, we said, like aspirin, some NSAIDs also. Aspirin inhibit the adrenergic stimulation of the bronchioles, and these are some of the specific pathophysiology related to the certain allergens. And drugs, and so all of this, all of this slide talks about the specific types of allergens and the pathophysiology associated with them, and try to explain the association between the allergens and the development of the asthma attack. And here we have the slide talks about the normal bronchioles and lumen of the bronchioles, and when there is an asthma, how the alveoli would collapse of the alveoli. And we have early phases, a late phase. So early phase of the asthmatic attack or response, and then the late phase of the response. clinical manifestation of asthma, the main or the major manifestation would be the wheezing. And that's because of difficulty with air movement into the alveolar or into the bronchial tree. And that patient will feel as if they are, going to suffocate. And the anxiety that's associated also with the asthmatic attack. Very anxious because they cannot take their their breath and they feel like they are going to suffocate. So that's why they will have that feeling of anxiety and the feeling that as they are like dying because they cannot take their breath. Now the silent chest, it's an ominous sign of impending respiratory failure. So, which is a safety alert here about the silent chest. And this is a very important concept in the asthmatic attack management or taking care of patients with asthma attack, is that if the patient has been wheezing, so the wheezing, it's like when a patient has a temp, we know that there is something is cooking, right? We know that's an infection, and that's a good sign. That's good that patient is febrile, because that could alert us that there is something is cooking and there is infection. Same thing here. The wheezing, it's good that the patient is wheezing, so we know that the patient is experiencing the asthmatic attack. So if the patient has been wheezing and there is an absence of the wheeze, that is called silent chest. So all of a sudden, patient stop wheezing. So, and the patient obviously, when they stop wheezing, looks like they are struggling, and which means that that's life-threatening situation, and that's when we recommend and we should request a mechanical ventilation. So once the patient is kind of has constant wheezing, continuous, and then all of a sudden stop wheezing, and patients start to have that to experience the struggle for breath, that is life-threatening, that may require that we have to start the mechanical ventilation. Yes.
That will be before we provide them with medications, right? Like if
Obviously, yes. Obviously, that would be patient as you're receiving a patient in the emergency room, right, with an kind of advanced scenario. Yeah. Mm-hmm. Yeah. But most of the patients, they know how to take care of their attacks. They have their own instant medications, inhalation therapy. They know how to manage the attacks. But in case that patient doesn't have the med or knowledge deficit or or no access to any treatment or any, so that would be the case. During the acute attack, patient become severely hypoxic. So the hypoxemia would be manifested in restlessness, increased anxiety, inappropriate behavior, increased pulse, pulse and blood pressure, and what is something called pulsus paradoxus. The pulsus paradoxus, that's one of the advanced principles in critical care, and we can define it as a drop in systolic blood pressure during the inspiration. And this requires, I would say, an experienced and proficient nurse and practitioner to be able to identify and to measure the pulsus paradoxus and say, and say that it's present or not. So the presence of the pulsus paradoxus, that's when there is a drop in the systolic blood pressure during the inspiration for more than 10 points. So if you take the blood pressure during the inspiration and expiration, you will time the blood pressure, the systolic, with the inspiration and see if that's going to be higher than 10 points than during the expiration or not. And that requires a lot of experience, and that's why it's one of the most difficult measurements and concepts and in critical care in terms of the assessment, like physical assessment concepts. Now, the most important, part or piece of the management of patients with asthma is to prevent the complication. We don't want them to reach or go to that, dangerous, life-threatening scenario in which that they will experience status asthmaticus, which is a severe life-threatening attack that is going to be like patients is having the scenario or asthma attack for a long period of time. So the time is a key in terms of the management of patients with asthma attack. The faster you take care of the asthma attack, the successful you would be, on that your patient is not going to regret, or patient to develop the status asthmaticus. And we have different causes of why patient would go to that, or develop the complication called status asthmaticus. The other complications of asthma, patient may develop a pneumonia or atelectasis, which is the destruction of the alveoli. In addition to the pneumothorax and the pneumomediastinum, acute cor pulmonale, and acute cor pulmonale, which is the cor pulmonale, which is the increased pressure around the myocardium. More fluid develop, and then creates more pressure around the myocardium, around the heart, and that will decrease its capacity and its compliance and its ability to work as a pump. Diagnostic tests for the asthma. The management. So the collaborative care of patient or management of patients with asthma. In pharmacology, you went over the medications to, that would be prescribed for patients with asthma, and these are some of the meds. It depends on the level of the asthma attack, if that's mild versus moderate or severe. And most of the time, patients will, it's a chronic disease. Patient will have, during the exacerbation of the disease process, then patient will have the severe attacks that they might be treated in the mid-surg unit, and most of the time that will, they'll be, taking care of their own disease at home, self-management of the disease, and that would be during the when the disease is not during the exacerbation, which is remission. So during the remission, patient self-management, home, right, or nursing home. But when during the exacerbation, that will be in the hospital for the management of the exacerbation of the disease process. Either asthma or COPD, both of them. You pretty much will see them during the exacerbation at the mid-surg units being taken care of and receiving some steroids like intravenous and other antibiotics intravenous, IV. So during the acute attack, we need 3 things. The first medication, or therapy, would be the oxygen. Second would be the beta adrenergic agonist. Which is the SABA, right? The short-acting. You learn about this in pharmacology. SABA, SABA, right? The short-acting beta agonist. And then the corticosteroids. So the treatment for the status asthmaticus, that is quite different than taking care of patient with just acute attack or episode, But during the status asthmaticus, we have to give all these medications, IV steroids. During the acute attack, if the patient is not developing the status asthmaticus, the steroid could be like in a tablet form, PO tablet form, oral. But when it's the status asthmaticus, that's a severe life-threatening scenario, you have to give the steroids intravenously, in addition to the magnesium sulfate intravenous and oxygen and the rest of the list here. So this is a scenario when you have a patient who would develop the status asthmaticus, and most of these patients who may deteriorate to that level is either due to the under management or the absence of the management, like no management or poor management, due to either either access to care or no access to care, or knowledge deficit, or these are the scenarios when the patient will develop the status asthmaticus. The long-term control medications to achieve and maintain the control or persistent asthma. The quick relief medications, that's to treat symptoms of the exacerbation. The bronchodilators, and we have a long list of bronchodilators. The onset of action in minutes, the duration, it takes about like 4 to 8 hours. So in about like 4 to 8 hours, patients may require another like inhalation therapy, and they have their own handheld inhalers, and they can take the inhalers themselves, right? So they know how to use it, and they will have it there, So that requires a lot of dexterity and a lot of like experience and knowledge base, and needs a lot of teaching. So in addition to the ability to hold the inhaler and take the the inhalation therapy, the treatment of choice in acute exacerbation is the bronchodilators, which is the beta adrenergic agonist, which is the short-acting beta agonist. That's SABA, S-A-B-A, short-acting beta agonist. Like albuterol, one of them. Either you can have it like handheld inhaler, or you can have it as a small ampule or small like container. You open it, put it in the machine, and you take it as the inhalation. The overdose. Sometimes the patients keep taking like these inhalation inhalants, or inhale take more than required or prescribed. When they abuse or take more than required of this drug, which is overused, that can cause the rebound. What do you think? You got this from in farm, right? It can cause rebound bronchospasm. It can defeat the purpose of the the disease of the treatment. Instead of opening the and treating the asthma, or opening the airway, it will result in rebound bronchospasm. To avoid contact with tongue to decrease side effects, what would you encourage patients to do after the use of the inhalation therapy? And especially when it comes to a drug like the Advair Discus, for example, like a powder form, in which they take the puff. They take about the 1 or 2 puffs per dose. Those purple square, like a circle devices, in which that they will activate, and they will take the puff for 2, and that will be the dose. It's a powder form. What would you encourage them?
To rinse their mouth after.
To rinse them out after. That's very important. That's a significant amount of information to tell the patients to to wash wash their mouth, or swish and spit and that would be like, the how to prevent the side effect that otherwise that could result or cause the growth of the microorganisms, especially fungal infections, and that results in thrush and fungal infections. Another set of drugs or medications to be prescribed would be the anti-inflammatory drugs like steroids, and the anticholinergic drugs like ipratropium, which is bronchodilator also. The steroids, which also is going to dilate the bronchioles, but the mechanism is going to be different than the drugs like the anticholinergic drugs. So let's say that a scenario of a patient is supposed to receive both the steroid and the short-acting beta agonist. Short-acting beta agonist and steroid. So what would you recommend, or how would you educate the patient? Take which one first?
The short acting.
The short-acting, and then the steroids, right? That would give more, better effect because you will dilate the bronchioles, and then the steroid would have a better effect on the dilated and open airways. So we will encourage them to take the short-acting and then the So we have lots of medications here to review under the asthma treatment. Any questions so far? So under the management, we have something called a peak flow meter. And this is one of the devices you might come across or you see in the hospital. So just to know how to so we know how to use it and how to interpret the results if you're going to use this type of device. So the peak flow results, if it's in green zone, it's the interpretation of that would be we will keep the patient, patient is good, so in good status, and we can remain the patient on same medications, so no changes in meds needed. So patient, we say that the patient is like 80 up to 100% of personal best of their breathing, they are good. But if it's in the yellow zone, then it indicates caution and that something is triggering, like the asthma attack is imminent, and the patient is about like 50 to 80% of personal best of their breathing, and it's just to be cautious and just to be ready for the attack. And when it's in a red zone, that is, it indicates that patient is having a serious problem, and that the definitive action is must be taken with the healthcare provider, and that's because about 50% or less of personnel best of their breathing. So that's about the asthma. The asthma, I'm sure at least you have having known, others, or friend of you or your family, or or taking you took care of a patient with asthma somewhere in the hospital during your clinical experience. But it's kind of one of the, again, the prevalence, given the prevalence of asthma, is that everyone has came across like at least just one case of asthma in their lifetime. So you just read about the manifestations, the treatment, a lot of medications to review about the treatment of asthma and the prevention of the complications, especially the status asthmaticus. Next is the COPD, which is chronic obstructive pulmonary disease. And also in pathophysiology, we briefly went on covered the pathophysiology of the COPD and the definition of COPD, because we have different types. We have, or under COPD, we can classify emphysema and chronic bronchitis. And given the difficulty of diagnosing patients if they are emphysema or versus the chronic bronchitis, most of the time in their chart you'll find just COPD. They don't go into like classification of saying that this patient is emphysema or versus that patient is chronic bronchitis. And if I out of the 100, you're probably gonna see like only 2 or 3 of them will be diagnosed with either one. But most of the time, you will see a patient as COPD, as either as current or a past medical history. So how to diagnose, or what is the indication or criteria for diagnosing a patient with COPD? It's based on the scientific concept that the COPD will be considered as a diagnosis based on the presence of chronic productive cough for 3 or more months. So like persistent, like 3 continuous, consecutive months, patient is experiencing chronic productive cough for these 3 or more months in each of 2 successive years. It has to be that specific to be able to diagnose patient with COPD. So presence of chronic productive cough for 3 or more years in each of 2 successive years, and a patient whom other causes of chronic cough have been excluded. So you have to exclude the other causes of cough that has resulted in the productive cough, like patients who work in places or like environmental exposure to certain things that results in, or patient or tobacco related. See how like people who smell like heavy smoke, they always cough, like constantly coughing. So that's from tobacco use or exposure. So that's just the criteria to diagnose patients with COPD.
Wait, sorry, can you say that one more time? You said persistent chronic cough for more than
presence
3.
of chronic productive cough for 3 or more years. Months. In each of 2 successive years in a patient whom other causes of chronic cough have been excluded.
So for 2 years, they have to have 3 months of a chronic productive cough.
Yes.
And just wanted to ask a question.
Yeah.
Does this come on at a certain age, or can you be younger and still get COPD? Because I know people who smoke a lot of cigarettes and they seem to have a constant cough all the time.
Right.
And they're young though, maybe 28, 29. Could they still have?
Yes, right. So in that case, it usually affects people over 40 or 50, or when it comes to COPD. If that's in that early age, then they have to go through what is called the pulmonary function tests, the PFT, which is pulmonary function test. That should be in addition to these 2 years too. I mean, that's criteria. regardless of the age. We did not mention any age, right? With the criteria, no no mention to the age. That could also be the case that if they they fit that classification or that criteria, then they will go through, because this is just one of the criteria. It's just one thing. Because anyways, that once they are defined, I mean, when they are classified as COPD, that would be confirmed. This is just a criteria, not confirmation of the disease. Would be confirmed with a pulmonary function tests. So that pulmonary function test, well, will confirm the COPD. Again, that's that could affect younger age. I mean, like 20s and 30s, and most of that from heavy, like smoking or tobacco exposure. So as you see here, the exposure to tobacco smoke, that's primary cause. Primary cause on etiology for the COPD.
Dr. Miki,
Yes.
the 2-year period that you mentioned, that's if the cause is unknown, or if they can relate the cough to any.
No. We said that we have to exclude the other causes of of chronic cough, excluding the other factors. Could be exposure to chemicals, or environmental exposure. So it has to be excluded. And you see how this whole slide talks about cigarette smoking and the effect of the tobacco on the lungs, and a specific mechanisms relates to the carbon monoxide and even how is the secondhand smokers also will be affected as well, and that effect on the pulmonary function and the even lung cancer. That would be also high stress for lung cancer. The COPD, they found also in terms of the genetic predisposition to the COPD that something called AAT, which is alpha antitrypsin deficiency, the known genetic abnormality that could lead to COPD. And that deficiency, even though that this alpha antitrypsin deficiency accounts for about less than 1% of COPD cases in the US, but it's the AAT. It's produced by the liver, and normally it's found in the lungs, and it leads to premature emphysema. If that's the case, if the patient has this specific alpha antitrypsin deficiency, that could result in a premature emphysema. That's a new association in terms of the scientific basis, or basis of the pathophysiology of COPD. So there are the pathophysiology of the emphysema. Chronic bronchitis, what identify or differentiate chronic bronchitis from the emphysema is that patients with chronic bronchitis, they would have a copious amount of thick secretions. That would one of the manifestations that may differentiate the chronic bronchitis from the emphysema. So the frequently airways are colonized with microorganisms because the excess or the large amount of mucus that are found and may occlude the small bronchioles, and that may differentiate it from the emphysema. So the chronic bronchitis cough would be patient, they don't have like an effective cough reflex. So cough is often ineffective to remove secretions. And that's because the patient cannot breathe deeply enough to expectorate and to cause the airflow distal to the secretions. In other words, that patient is unable to expectorate the secretions and mobilize them and remove them by the cough reflex. So their cough is ineffective. And this is the chart from pharmacology, for the treatment of patients with COPD in terms of the different levels of management or drugs to be added to the plan of care. So emphysema, one of the first signs is dyspnea. The main sign, major sign of dyspnea of emphysema is dyspnea. The over distension of the alveoli. So why the alveoli became over distended? Because the patient is able to inhale, but they have a very difficulty of exhaling and emptying the alveoli. So that will result in flattening of the diaphragm and the AP, which is anterior posterior diameter, to increase. So the AB diameter, which is the anterior posterior, so if the AP diameter has increased, that would result in like 2 to 1 instead of 1 to 2, because we say AP diameter versus the transverse diameter. Transverse diameter, which goes like from, let's say, like from shoulder to shoulder, that's transverse. And the AP diameter that goes like from back to chest, that's kind of give you the direction of the diameter. So that would result in patient to develop what is called the barrel chest. And you see very obvious in patients and when they have advanced COPD who had lived with COPD for several years, you will see that also they are underweight, they are malnourished, they have a very dusky and flushed face, and that's that face and the dusky flushed face, that's from the constant struggling with with the breath. And these are also other manifestations for chronic bronchitis, in addition to the thick mucousy secretions, constant. Complications of asthma, acute respiratory failure, even peptic ulcer disease, and GERD. And that's from the presence of the acid in the esophagus, which can cause the what is called the mediated reflux, which is the GERD, from the presence of the acid in the esophagus. And then pneumonia. These are some of the complications that patient with COPD may develop. ABGs, as you know, patient with COPD, classic scenario would be the decreased PaO2. They will definitely have an increased PaCO2, as respiratory acidosis. So the pH would be low, and they will have an increased level of bicarb that will be found in late stages as a compensation, right, for the respiratory acidosis. So in early stages of COPD, you will find that the bicarb level is within range, but eventually like few hours and a day of experiencing COPD and acute attack, that would increase the bicarb as a compensation to the respiratory acidosis. We use something in the spirometry. Spirometry, this is one of the pulmonary function tests. We rely heavily on this test to diagnose patients with COPD. We have something called FEV, forced expiratory volume, forced expiratory volume / over FVC, forced volume capacity. So that should be under the spirometry. So forced expiratory volume over the forced volume capacity, vital capacity, that will be reduced. In patients with COPD, it will be reduced. The ratio will be reduced. And patient would have an increased residual volume. So they have an increased residual volume because of the inability to exhale air from alveoli. That's why they have air trapped in the alveoli, and they eventually develop the barrel chest. So the ratio of FEV over the FVC will be reduced, but they would have increased residual volume and total lung capacity. The total lung capacity and the residual volume both increased, but this ratio will be decreased. And that's all of this kind of complications, or these results or measurements or results or values in response to the air being trapped in the alveoli. And patient doesn't have the effort to empty these alveoli from air. So keeps build up, air will build up in the alveoli and result in what's called the barrel chest. So collaboration of care and management is, first of all, the health promotion is to to smoke, smoking cessation, quit smoking, medications like bronchodilators, oxygen, which is basic. A patient will be on oxygen constantly. That will be lifelong, and that's patient will have either they will use concentrators like in nursing homes or home setting, or they use the oxygen tanks, oxygen cylinders, or central, like what you see in the hospital, like central supply of oxygen. And it has to be humidified. So humidification is a key when the patient uses an oxygen higher than 4 liters per minute. An explanation why would you, and we have to use humidification for O2 therapy when the rate is over 4 liters per minute.
Because the rate of the flow of the air is so high, it's gonna dry out the nasal passages.
Yes, absolutely. Yeah, that's the explanation rationale for for the implementation of humidification when the oxygen flow rate is higher than 4. At a lower rate, it doesn't, create this problem, which is the dryness of the air, mucous membranes. So this is adult health 1 stuff, and you learn about the NUR breather mask and the rebreather mask, and then we have the Venturi mask, and this is what is called the Venturi mask. And what's specific about the Venturi, or what good about the Venturi mask? What's the best characteristic and value of having Venturi mask?
It gives you precise oxygenation.
Yes, if you want to deliver the exact percentage of oxygen, this is the best one. So it's more accurate. It will give you exact percentage of oxygen because each device, because it has the color-coded devices with different valve sizes, and each size will give you a certain and specific percentage of oxygen to be delivered. So that's more accurate and the most accurate device to deliver oxygen for patients with COPD or asthma or even any respiratory problem. And then we have chest physiotherapy, postural drainage, positioning, cupping, clapping, vibration, and you learn about this, about this in also in adult health 1, health promotion to quit smoking, acute intervention. So all of these we just covered most of them. Okay, so next is lung cancer. I would just skip the slides that pertain to the pathophysiology and go to the etiology and risk factors or genetic risk and etiology for lung cancer. So the environmental tobacco smokers, ETS, inhaled by non-smokers poses about 35%. Imagine the risk that patient who's non-smoker but they are exposed to the second secondhand smokers, they are at risk for 35% risk to develop lung cancer. Other carcinogenic, and we have here lots of carcinogens that are listed as materials and factors or carcinogens that can result in or develop the lung cancer or cause lung cancer. The exposure to substances is common also for the employees of industries, certain patients who work in certain manufacturing or certain industrial companies, such as would be at high risk for lung cancer in terms of working in certain industries.
Could be like welding.
Yes, welding, smelting, mining. Patients who work in a chemical or petroleum manufacturing, they are at high risk for lung cancer. And the smoking will, the problem with smoking also is going to be a synergistic factor or effect, synergistic effect with these other chemicals. So again, the pathophysiology, I'm going just to skip that. Now, the common sites for metastasis, let's see here. Metastasis. So lung cancer is metastasized by, these are the three main, vehicles and ways in which that, lung cancer, either the lung cancer is going to be the primary cancer or the secondary cancer. So the common sites for metastatic growth, if the patient developed lung cancer as a primary cancer, like initially the cancer is the primary cancer, lung cancer, then that may metastasize to other adjacent or distant organs like liver, brain, bone, and adrenal glands. These are the most known places or organs or tissues in which that the lung cancer may metastasize to. So, which is again liver, brain, bones, and adrenal glands. Liver, brain, bone, adrenal glands. And again, in cancer development and the metastasis, sometimes there is no scientific explanation why would the cancer cell would will metastasize to certain organs. There is no like scientific explanation or any basis for science to explain why certain cells or cancer cells transfer, will metastasize to certain distant, especially when it's distant organ, and adjacent, we know it's next to it, so that would be like an infiltration, or what is called the local seeding, like shedding. The cells will be shedded to the next to the adjacent organ. But when it comes to distant organ or tissue, that is sometimes very difficult to even to explain, because we know that it's either the blood or via lymphatic fluid. But at some point, sometimes it's very difficult to explain. The staging, so it's just before that pneumocystis. The symptoms may be masked by chronic cough. So pneumocystis, I don't know what is pneumocystis is. It's the part of the fluid around the lungs, when there are secretions and pneumonia. So it's persistent pneumonitis. So it's like pneumonia and secretions around the lungs, and that which sometimes result from the obstructed bronchi, and that would be one of the early manifestations of lung cancer, because that is going to cause also fever and chills and cough. But the pneumonitis is persistent secretions from the pneumonia that would result from the obstructed bronchi, and that would be one of the early signs or earliest manifestations of the lung cancer. Most common also with lung cancer, persistent cough with sputum, and sometimes palpable lymph nodes would be noted in the neck and the axillary lymph nodes, palpable, the neck, around the neck too. The mediastinum, which is the space in which was the the heart is located, and that's the mediastinum. That's space between the cardiac and the myocardium, or the heart and the lungs. This are the space, and so that's called mediastinal space. So that's mediastinal involvement may lead to pericardial effusion. So if there is fluids there, that will result in what is due to the pericardial effusion, in addition to the cardiac tamponade. Cardiac tamponade, which is the collection of secretions around the myocardium. Cardiac tamponade.
Can you say what's the cardiac tamponade again?
Cardiac tamponade, which is a collection of fluids or secretions around the myocardium. In terms of diagnosing, the CT or CAT scan, it's the single most effective non-invasive technique to evaluate patients with lung cancer. CAT scan is the single most effective technique for evaluating lung cancer. For sputum specimen obtained for the cytologic studies, to do the cytology or cytologic studies from sputum specimens, you can do it through. There are different ways of doing it. Either through the pulmonary angiography, you can do fiber-optic bronchoscope. There is something called VATS, which is video assisted bronchoscopy. So there are different ways of doing that sputum specimen obtained for cytologic studies. Staging, as we know that we have a TNM staging system. We learned about this in pathophysiology. The problem with the staging system, especially we have two different types of lung cancer. The non-small cell lung carcinoma, which is NSCLC, non-small cell lung carcinoma. The staging of small cell lung carcinoma, so we have small cell lung carcinoma, and we have the non-NSCLC, and then the SCLC. With the small cell lung carcinoma, staging for this one by the TNM has not been useful. So it's good for the non-cell lung carcinoma, non-small cell lung carcinoma. So for the small cell lung carcinoma, it's not been useful because the small cell lung carcinoma is very aggressive and is always considered systemic. Because of the aggressiveness nature or development of the disease process, it hasn't been useful, that staging system, then TNM system. So two different types of two different levels of staging, and we'll give you an example of how the staging is important and not just diagnosing and understanding, at which, level or stage the patient will be at, but also it will guide professionals and guide, practitioners to the treatment and the plan of care too. So patients with stages 1, 2, and 3A, like Roman numbers 1, Roman number 2, and Roman number 3A, patients with these stages of the lung cancer disease may be a good candidate for surgical interventions. However, patients in stage 3B or 4, they tend to have poor prognosis. So if we put here 1, stage 2, stage 3A, this group of patients, they'll be a good candidate for surgical interventions. And we have 3B and 4. This group of, or patients at that stage, if we stage them at 3B or 4, then that's usually inoperable. So they are not good, candidates for the surgical interventions, and they have the poor prognosis. Then they will, choose for them, or will be a candidate for other therapeutic modalities, not the surgical intervention. So surgery, surgical intervention, radiation, chemo. Chest physiotherapy, and then we have the chest tube. and part, one of the skills modules skills is to take, how to take care of a patient with chest tube, and we will revisit this in adult till 3 and focus more on the insertion, maintenance and nursing care of patient with chest tube. And next is the chapter that talks about the flu, and I will just leave, the flu because that's the kind of easy stuff you can read on your own, and then it's just to focus on the two things, the pneumonia and the TB, and highlight just important things from pneumonia and the TB. So pneumonia, and we have different types of pneumonia. The etiology, pneumonia, the mechanism which would be impaired, which is the mucociliary mechanism that will be impaired. And we have different reasons or causes and factors that may result in the alteration of that mechanism. Pollution, cigarette smoking, infections affect the upper respiratory infections, intubation, aging. So different types of pneumonia, classification or types. And this is critical. We have, as you know, that most of, or maybe some of the infections now, hospitals that they are not going to be reimbursed if the patient developed the infection while or during hospitalization. So if the patient developed the hospital-acquired pneumonia, the insurance company is not going to, reimburse the hospital. So there is a strict surveillance now, in addition to the documentation regarding the these type of infections. Same thing with the pressure ulcers and decubitus ulcers. If the patient need to develop that during the hospitalization or during the or while being in a nursing home, or same thing if they develop the UTI, urinary tract infections, and in addition to this one too, which is the hospital acquired pneumonia. So it's critical to understand the criteria and the classification, how to classify this one from the community acquired pneumonia, or if the patient has the VAP or HCAP, which is health care associated pneumonia. So the first one, which is the community acquired pneumonia, and that's when the patient developed that when the onset. So we have to look at the onset of the pneumonia. The onset has to be in the community or during the first 2 days of hospitalization. So as long as the first, second day, patient had admitted, and then today or tomorrow, patient is going to develop these symptoms, that's still going to be considered as community-acquired pneumonia. After the second day, from 3 days on, that will be considered as, like after 48 hours of hospitalization, then that becomes a hospital-acquired pneumonia. So that's the hospital-acquired pneumonia would be any pneumonia occurring 48 hours or longer after admission and not incubating at time of hospitalization. So definitely after the 48 hours of hospitalization, patient developed pneumonia, that is going to be hospital-acquired pneumonia. Before the 48 hours, since patient has been hospitalized, still will be community-acquired pneumonia. So hospital-acquired will be after the 48 hours of hospitalization. And the risk factors for the hospital-acquired pneumonia would be, who would be at risk for the hospital-acquired pneumonia? Patients on certain medications which suppress the immune system.
Cortisone medications.
Yes, cortisone, steroids,
Yeah.
which is an immunosuppressive agent, or any other immunosuppressive therapy or immunosuppressive drugs. In addition to the, older adults will be at risk too because of the general debility. or also patients who would be intubated, like what is called intertracheal intubation. The VAP, which is patients on the ICU, also they will be at risk for VAP, which is ventilator-associated pneumonia. And then we have the HCAP, which is healthcare-associated pneumonia. So that's the health care associated pneumonia. That's a new onset of pneumonia, and a patient who was hospitalized in acute care for 2 days or more, patients who reside in long-term care facility, patient who receive IVs, antibiotic or chemo, and patients who attend the hemodialysis clinics. They have like end-stage renal disease, and they go for dialysis 3 times a week, and they will be at risk for the health care associated pneumonia. So we have also aspiration pneumonia. Older adults, when we aspirate and then they develop, and that will be known to those of you who work in nursing homes. How many times you have patients start coughing and just they will ignore it because patient aspirated or patient choked, and then nothing to follow up, or there's no follow up, and then the patient developed pneumonia. So pneumonia could result from the aspiration. Patients who have difficult swallowing, or patients with nasogastric intubation, or patients with PEG tube, right? Because we have to prevent the aspiration so aspiration precautions, we call it, right? So we call that aspiration precautions by elevation of the head of the bed. So NG tube, PEG tube, at all times, patient's head of bed should be elevated. The only exception would be just, during the, patient care for a few minutes until we change the patient's linens or patient sheets and change the bed linens, and that's the only reason, or change patient's position, or repositioning the patient, or change the patient's sacral wound dressing, for example. Or there are just only exceptions in which that patients with NG tube or PEG tube, not in a should not be in a flat position or supine position or flat, and always we have to maintain aspiration precautions by elevating the head of bed between 30 and 45 degrees. And the opportunistic pneumonia, which is the last one, which is the pneumonia that could result from the weak or immunosuppression, weak immune system or immunosuppression. Patients at risk who may develop the opportunistic pneumonia due to severe protein calorie malnutrition, immune deficiencies, patients on chemo or radiation therapies, or patients on long-term steroid therapy. And an example of that would be like patient with HIV/AIDS, and when they develop what is called PCP, pneumocystis carinii pneumonia. So they would have fever. Manifestations of that would be fever, tachypnea, tachycardia, dyspnea, non-productive cough, hypoxemia. And these are the known manifestations of pneumonia. In addition to that, patient may develop complications. And one of these complications is meningitis from pneumonia. So anytime you see a patient with pneumonia became like confused, disoriented, any changes of alteration, any alterations of mental status, somnolent, like lethargic, then we have to consider the lumbar puncture or spinal tap to rule out the meningitis. Diagnostic tests, mostly will, in addition to all of what listed here, like history, physical examinations, and gram stain of the sputum, gram stain. The most important one here is the chest X-ray, because it will show patterns of a characteristic of the infection. So ideally, the sputum specimen for culture and gram stain, we do that to identify the organism. And these are obtained before we begin the antibiotic. So the antibiotic shouldn't be started before we get the sputum culture and I mean like sputum for culture and stain, or stain and culture. We will do this, on the specimen, send it to the lab, and we can start the antibiotic right away. Pneumonia vaccine, we know that the pneumovax or the pneumonia vaccine should be given once every
5 years.
hold on, 5 years. Yeah, it's good for 5 years. The flu vaccine, as you know, it's annual every year, right? So the pneumonia vaccine is 5 years. We have criteria, and we have this is explains the criteria and the exclusion and inclusion criteria for the pneumonia vaccine. And we have here the bottom of this slide says ventilator bundle. These are in the ICU, like in the intensive care unit. Patients on mechanical ventilation, we attempt to, by maintaining and maintaining the strict aseptic technique and asepsis, we want to prevent this pneumonia from happening, which is the VAP, ventilator associated pneumonia. And the ventilator bundle, provides you with like a table in the book. It's a group of interventions. Specific interventions can be done and performed, and the aim is to reduce the risk of the ventilator-associated pneumonia (VAP), and it has shown, based on like evidence-based practice, that these bundles or these interventions, it has reduced the VAP by as much as about 88%. So that's evidence-based practice that the ventilator bundle interventions had reduced. So we just go, go to that table and see what specific like interventions are there as nursing interventions to reduce the VAP. So the last topic, which is the TB, tuberculosis, and the tuberculosis is an infectious disease. And for those who hopefully in March we'll go back and resume clinical to St. Joe's. We go to the unit, mid-surg unit, but the designation of that unit is infectious disease. So infectious disease, which means that you will see, definitely will see cases of TB, either ruled out or suspected or confirmed cases of TB, tuberculosis. And when it comes to tuberculosis, we always say it's think it's only lungs. It affects the lungs. The tuberculosis, the TB, it can affect any tissue, any cell, not just the lungs. We had a patient last year, last fall, in adult health 3, we had a patient with TB in the right, I believe it was the right or left hip. So it affected not the lungs, it affected a wound. The wound was infected with TB. The hip wound was infected. So it's Mycobacterium tuberculosis. It's a bacteria. It can affect any organ, any disease. Any tissue, any cell. But mostly, the most prevalent and most frequently affected organ always the TB, and we always talk about the TB as pulmonary TB. We don't usually cover the other, organs or cells or tissues, but mostly we say pulmonary TB. So pulmonary TB, we're focusing here on just the lungs, the tuberculosis of the lungs. So again, worldwide is the second most common cause of death from infectious disease, the TB. So under developed countries, it's going to be more prevalent than developed countries. Resistance is a big problem. That's one of the major problems that would encounter professionals, which is the resistance. And that's either from incorrect prescribing the meds, or from lack of public information, like public health case management, or from patients' non-adherence to the prescribed regimen. Incorrect prescribing or lack of public health care case management, or patient non-adherence to the prescribed regimen. That's why there is resistance that would result from these problems or due to these factors. Now, anytime you have a patient with these symptoms like significant loss of weight, so weight loss, fever, night sweats, chills, productive cough, pleurisy or pruritic pain, in addition to hemoptysis, dyspnea, sometimes, not necessarily, but it's unusual, but sometimes patient has dyspnea. But the most important ones, or manifestations, would be the fever, chills, pleurisy, productive cough, hemoptysis, in addition to the weight loss. Night sweats are significant because of the activity of the bacteria during the nighttime, during sleep. So trying to be active during sleep because the immune system is not quite active. So these are the most common signs and symptoms, manifestations of the TB. Now, how would you diagnose TB?
With the intradermal test.
Right. the skin test. So the patients who had or like previously been infected and they don't have an active TB disease right now, they are referred to as a latent TB infection, LTBI. That have been infected in the past, but now it's inactive.
So once you get the TB, it stays with you for life. There's no getting rid of it.
No, they'll be treated for the activity of the disease that may, but it becomes like a vesicles in the lungs, and these are nodules in the lungs that stays permanent.
But it's not a virus.
No. It's just necrotic tissue that is there, and that could result in it's dormant. It's a bacteria, anyways, right? So it's dormant. It's dormant, like it's inactive, but it can become active anytime because it's very similar to what is called the shingles and herpes zoster disease. And if patients like immune system becomes incompetent, patient become malnourished, become, so in these scenarios that it may reactivate, become active.
Dr. Miki, what
Yes.
if a person only comes in contact with it and has like traces of the TB? What happens?
I'm sorry, one more time.
What if, like, let's say the person gets tested, but it doesn't have TB, but instead had traces of TB? Don't know if you heard
No
of it.
infection, but traces. What do you mean, traces?
Like it was found, the tested was reacted on the skin. I don't know.
Okay. The reaction, I'll talk about the reaction because the reaction is one of two things. Either the patient's been exposed to the bacteria as a disease or as a vaccine. If you've been vaccinated for BCG, then your body has reacted to the BCG vaccine and resulted in an immune reaction. And that immune response will be permanently, and I would say like maybe like not large percentage of people will have that permanent. In other words, that anytime you're going to be tested for PPD will show up as positive, but your lungs are clear, no nodules, no permanent vesicles, there is no any residual in the lungs, which means that you have never been exposed to the disease itself, never been infected, but you received the vaccine, the PCG vaccine. And this vaccine usually given in like underdeveloped countries I believe that it's, the second week of newborn, second week, the newborns usually receive it, and, on like, day 14 or, second week of life, they receive the vaccine, the BCG vaccine. And that's why they will be tested positive for PPD because they have been exposed to the vaccine, which is it's an attenuated bacteria because they had developed the immune response, but they never been exposed, never been infected. So what we do is that anytime you will see a positive result, we will confirm it with the chest X-ray. As long as the chest X-ray is clear, then obviously we know that most likely that this person has received the BCG vaccine. So the transmission of it's an airborne, right, microorganism. So the transmission requires close, frequent, and prolonged exposure. Doesn't mean like if you get in contact with with a patient with TB, like in a second you will get infected, but we'll take our precautions as much as we can. So in the Reagan 6 South at St. Joe's, we have that unit. We go to that unit, which is the infectious disease unit, and we have large number of rooms now, even especially because of the COVID now, they have more rooms, but used to have at least 5 rooms equipped with negative pressure. So these rooms are necessary for patients with TB. We need the patient, two things, airborne precautions, N95 mask. Second, we need the patient to be in a room equipped with negative pressure. So the PPD, as we analyze and measure the PPD test, there is a criteria. According to the CDC, we have specific criteria about the measurement of the test, of the PPD. You see how is the ruler or the measure, the PPD measure the redness as part of the nodule or part of the induration. So the induration, as you measure the induration, you include any redness, not just the raised induration, but also any redness will include into the calculation of the measurement. And we have different numbers when it comes to the measurement of the PPD. The CDC, they go any number over 10 millimeters, any competent immune system with person with competent immune system. So any number over 10 will consider as positive. However, patient with like suppressive on immune suppressive drugs or with immunodeficiency disorders like patients with HIV/AIDS, patients on steroids, patients on immunosuppressive medications, we will consider any number over 5. So we have to differentiate between the healthy or patient or person with no immunodeficiency disorders, not taking any immunosuppressive agents. That would be any number over 10. However, patient who is immunodeficient and they have an immune system problem or deficiency or taken immunosuppressive agents or medications, then we will consider the 5 or over as positive for TB. And that's because of the immune system is incompetent and won't be able to elicit the immune response. So we're not going to rely on the 10 or over for the patients with immune deficiency, with HIV/AIDS, for example. So any number over 5 for them, that would be positive. But what confirms the diagnosis will be the sputum for AFB, acid-fast bacillus. And nowadays we have also the quantiferon TB test, and that's very fast. The EFB, that's what confirms the diagnosis. Now, just very quick, we have like 1 minute left. Just to, I will highlight things, and you will read your own, but make sure that you go over the drugs, the 4,000 medications. So this is the vaccine I was referring to, the BCG. That's anyone who had received this during the newborn life, the first 2 weeks of life, then they will develop their body will elicit the immune response, and they will be mostly, I'm not saying all the time, but mostly those people who would be tested positive for PPD all the time. And for some people, they will at some like certain age, they will stop showing that response or immune response and shows as negative. But if it's positive, then that could be related to that or caused by the BCG vaccine. Now, just make sure that you review the medications, the 4 different types of meds for the TB, the regimen we use for TB, So this is the regimen, especially isoniazid, INH, rifampin, ethambutol, and pyrazinamide. So isoniazid, rifampin, pyrazinamide, and then we have ethambutol. These are the 4 most important meds, because when we say TB protocol in terms of medications, that will be the 4 medications. And each med has a, make sure that you know the side effect, because each one has a side effect, and we know how to address it or how to counteract the side effect. So the 4 drugs and the side effect of each one, and nursing implications for the drugs. Did you cover the anti-TB drugs in pharm? No? And okay, so you know the answers, I can easily just put the answers in the blackboard with the rationales too. So any questions, because I have to stop because you have another class to go to, right? So you have to go to your OB Peds class, right?